A very good evening to everyone and welcome to our 10th session of the Genomics series, where we talk about how genomics is being utilized in different clinical and healthcare settings. My name is Azadara, your host for this webinar and working as a bioinformatician at Cartoonist Healthcare. Today we have with us Dr. Amit, who is currently associated with Manipal Hospital as the head of the department and consultant medical oncologist. Today, he is going to speak about clinical implications of HER2-NEU mutations in lung cancer. So before we dive into his insightful presentation, I would like to highlight that he has over 20 years of experience in cancer care and has contributed significantly to the field of immuno-oncology in India. Dr. Amit is passionate about newer modalities and their integration. He specializes in treating hematological malignancies as well as specific solid tumors like lung, breast, GI, head and neck cancers, and is also a part of several ongoing oncology clinical trials as a principal investigator. And besides his illustrious clinical and academic background, Dr. Rauthan is a respected voice in the medical community, often engaging in discussions on the challenges and future directions of cancer care. His holistic approach to oncology, balancing cutting edge science with genuine care and compassion, makes him a trusted figure in the field of cancer care. Without further ado, I would like to welcome Dr. Amit. Sir, the stage is now yours.
Thank you very much. Good evening, everyone. I thank Kakinos for this opportunity. Yeah, great. Are my slides visible?
Yes, sir.
Okay, great. So today, the topic I kind of wanted to talk about was clinical implications of HER2 alterations in lung cancer. And I kind of find this topic very fascinating because we talk about a lot of other mutations in lung cancer, and this is a small space, but it's really changing very rapidly, and it's changing how our patients respond and how our patients fare when they have these mutations. So we all know lung cancer, adenocarcinoma lung cancer, we have divided that into molecular subtypes, and we now don't treat any adenocarcinoma without any molecular reports. And we've said we know about the 10 subtypes. We talk about EGFR, ALK, ROS. We talk about BRAF, RET, MET, KRAS, NTRK. And we also talk about this small subgroup of ERBB2 mutations or HER2 mutations. And we learned very early that lung cancer HER2 mutations are more important. And because we were in the breast space, we always had HER2 in breast, and we always learned HER2 expression or HER2 overamplification. HER2-NEU 3+ is very important in breast. But what we are learning slowly, breast and lung are different, and that's where we wanted to clearly divide how it differentiates and how our patients do with this. So let's talk about the HER2, first about the HER2 receptors. We have 4 HER receptors. We are talking of HER1, which is also called as EGFR. We have the HER2 receptor, we have the HER3 receptor, and the HER4 receptor. Now, all these receptors, they have the 3 parts. They have the extracellular domain, which is the ligand binding domain. There's the transmembrane domain, and then there's intracellular domain, which has the tyrosine kinase activity domain. Now, uh, important to note, HER2 is unique because HER2 does not have a ligand of its own to bind. All the others have their own ligand. And another unique thing about HER3 is HER3 receptors don't have their own TKI activity. But what we have learned, there is very potent dimerization when HER2 and HER3 dimerize. So HER2 gets activated by heterodimerization with HER1 or HER3 or HER4. And there's also sometimes homodimerization happens. But this HER2, HER3 dimerization or HER1, HER2 dimerization is what is leading to a potent downstream signaling. So when these dimerizations happen, we talk about PIK3, AKT, mTOR pathway activation. We talk of the RAS, RAF, MEK, HERK pathway application. And this is where the downstream activation is causing the cell to multiply, leading to increased proliferation of the cells and increased activation of all the pathways. Now, this pathway we have understood, and whenever we used to see breast cancer HER2 3+, we knew we were looking at IHC and amplification. And we learned early in lung cancer, when you see HER2 expression, it may not be that important. What's more important is HER2 mutation. So what we are learning, there are three abnormalities of HER2 which can happen in lung cancer. The HER2 alteration can be a HER2 mutation, which is probably the most important pathway of driving a lung cancer. There can be a HER2 amplification, and there can also be HER2 overexpression, or the HER2 3 plus can also be seen in lung cancer. But what is most dominant and most important is HER2 mutation, and that's the driver mutation in lung cancer. Now, understanding HER2 mutations, they're about seen in about 4% of non-small cell lung cancer. We've seen various data sets. They range from about somewhere about 2.5 to 5%. And uh, this is this is probably uh, the, the, the range which you will see, but it may vary from different, depending on how the testing has been done and depending on various platforms, depending on various places. It requires an NGS testing or a PCR testing. We are seeing it much more nowadays in lung cancer because we are doing more and more NGSs and more comprehensive NGSs. Earlier, there was a time when we did single gene testing, and we used to always look for EGFR AL cross, and we used to miss this kind of mutations. Then we started doing gene testing, selected single gene testing, selected NGS testing, and even then HER2 was not included in all the panels. We used to miss this test, but now that we are doing more and more testing, all of us are seeing a lot of more HER2-NEU mutations in our lung cancer patients. Now, it has been seen that they are more common in females, they are more common in non-smokers and adenocarcinoma histologies. But again, we always say don't put it as all non-smokers and females only. It can be seen even in males, it can be seen in smokers. So test everyone when you are doing an NGS testing. They are sometimes, they are usually always mutually exclusive with other oncogenic drivers, and that's the reason why HER2 mutation is a selected driver by itself. If you look at where are the HER2-NEU mutations, most of these mutations are occurring in the tyrosine kinase domain. Now, again, in HER2-NEU mutations, we say the most common is the exon 20 insertions, but if you look at the number of mutations, there are multiple of them. There's something like EGFR exon 20 insertions. When we talk of the EGFR space also, we similarly talk, there are multiple mutations. They may vary depending on what position they are in. And similarly, in the HER2 mutations also, in the exon 20 insertion, there are multiple of them. Now, most are in the tyrosine kinase domain, but rarely they can also be in the extracellular ligand binding domain and other regions also. Now, it is becoming kind of difficult for us in clinical practice because we don't realize these are such a long list of mutations, and for us as clinicians, it becomes difficult. But there is so much fine-tuning happening now, saying that depending on the HER2 exon insertion mutation, you may have a different kind of a presentation. Some of them will have a propensity for more brain metastasis, and some of them will have less brain metastasis, depending on the type of exon 20 insertion mutation you have. So suddenly, the field has changed so rapidly from talking of just saying, you had a HER2 mutation, you're now talking of, yes, you have a HER2 exon 20 insertion. Then you are talking of, you have a HER2 exon 20 insertion mutation, which may be the A775G776 insertion YVMA type, which may have a more propensity for brain metastasis. So again, it's getting really into details, but for us as clinicians, we say we should know that our patient has been looked for a HER2 mutation, and a HER2 exon 20 insertion mutation is the commonest mutation which we find. Now, apart from HER2 mutation, we can also see HER2 amplifications. The frequency is about 3%. They're not very common. Usually tested, they're found in the FISH test, or they're found in the NGS testing. When you did a FISH, the HER2 CEP may be greater than 2. Now, de novo HER2 amplifications are found much more common in males and smokers, and it's been seen that they may have more aggressive features, like they may have a higher tumor size, they may have more pleural metastasis, they may have more lymphovascular invasion. There is also another situation where we are seeing HER2 amplifications, and that is in the EGFR mutant space. Now, these patients, EGFR mutants, when they are being treated with EGFR inhibitors, when they progress, we are doing an NGS, about 15% of patients may actually have a HER2 amplification, and this may be a bypass pathway which is getting activated and causing resistance. So another very interesting space of getting a HER2 amplification, because we're looking at resistant mechanisms to EGFR, and then we'll start looking at newer mechanisms of treatment. But again, HER2 amplification de novo per se has not been so important in lung cancer. It's just that we are learning about this a little more, and yes, it can be targeted. HER2 overexpression, this is the one space where we learned very early in lung, because when we started off breast, for us, it was always HER2 overexpression in breast, HER2 3 plus IHC, and this was not the same in lung. We learned that HER2 overexpression could be seen in a very wide range. It could be as early as low as 2% to 38%, depending on what studies you read at. It's much more common in males and smokers. But what we are learning more is HER2 expression is in lung cancer is typically not being driven by an amplification. It's much more driven by polysomy. And that's the reason why HER2 overexpression has never been something which can be targeted easily in lung cancer the way we did it in breast cancer. Giving trastuzumab for HER2 3 pluses never worked so easily in lung, is because it's not really it's not really the amplification, but it was more by a polysomy. And that's why IHC 3 plus in lung, when we caught it earlier, we used to disregard it too much. We said it's not too important for us. What we used to tell our patients, if you got a HER2, what is the HER2 alteration? And if they said it's HER2 overexpression, we said, oh, that may not be a driver really for you, and that may not be targeted. And we used to tell, yes, if you said it's a HER2 mutation, that was very important for us. And we told our patients, this is possibly a driver and this needs to be targeted. Now, when do you say it's polysomy? In lung, when you said, if you had a HER2 gene copy number greater than 6, but HER2 step ratio was less than 2, we believe these are polysomies and these are possibly not true amplifications which are happening. There's a lot of conflict and overlap. The reason is because you will see multiple times, there will be a HER2 overexpression, HER2 amplification, and sometimes you will also see HER2 mutation together in many patients. And there's always this overlap happening. And we are seeing much more and more as we are doing more and more comprehensive NGS testing. There was data saying that HER2 overexpression had a worse prognosis, but it really didn't change our treatment guidelines in many ways earlier. So most important for us in lung turned out to be HER2 mutations. And we said, how would we treat a HER2 mutation? Now, conventionally, chemotherapy was the standard of care, and chemotherapy is even now a standard of care for HER2 mutations as first-line therapy, though the standard of cares are changing a lot very rapidly. But what we saw, pemetrexed carbo was the chemo used. Again, it gave us results, but HER2 mutations didn't do so well as you would have expected other patients to respond. So there's a slight poorer response to the usual chemotherapy when you use chemotherapy alone. There's always a thought, if you why don't you just treat with chemoimmunotherapy the way you treat all other lung cancer patients who don't have the common EGFR AL cross driver mutations? But again, immunotherapy, in addition to chemo, in selected small studies showed that they don't really respond that well to immunotherapy. Even single agent immunotherapy gave us very poor response rates of only about ranging about 15%, and the duration of response was short. And even chemotherapy plus immunotherapy in HER2 mutations, when you compared with chemotherapy alone, actually did not really improve survival. There was a higher response rate slightly, but there was no improvement in survival. So chemoimmuno, though we say chemoimmuno for all our lung cancers without the common drivers, again, with HER2 mutations may not be the way forward. So the thought comes always, how can we block the HER2 pathway, and could we block it just the way we started blocking HER2 pathways in breast cancer? So let's see from the right side, when you look at the antibodies, trastuzumab, this is what we have had for our HER2 patients for a long, long time. In breast cancer, chemo plus trastuzumab is straightforward for our HER2 3 pluses. So this was tried even in lung cancer with HER2 mutations. And it was seen that actually in the refractory population, the response rates were very poor. Not many patients responded. And that's why trastuzumab never came as a treatment option for HER2 mutations. Now, there were trials looking at trastuzumab plus pertuzumab, because that's what you would do in breast cancer. So you did trastuzumab, pertuzumab, docetaxel, and small trials showed there were response rates ranging for about 29-30%, PFS about 6.8 months, but again, not great long-term responses. So that's the reason why this has also not been taken forward in HER2 mutations. The concept of using ADCs has, from breast cancer, been adapted to HER2 mutations, and TDM1 was first tried, And it actually showed a very encouraging response rate. In that small group of patients in the trials, overall response rate was 51% when you use TDM1, but then the PFS was not very great. It was about 5 months. So clearly, TDM was also not great, doing very well. But a few years ago, we actually talked about TDM1 for our HER2 mutations as the only uh, drug showing some amount of high response rates as an anti-HER2 targeted drug. Move to the left side, we also said, why don't we just block the HER2 pathway by using HER2 TKIs? And this is learning coming from the EGFR space. When we saw EGFR mutations, we looked at EGFR TKIs. Similarly, we said HER2, one could use a pan-HER2 inhibitors, and that's where trials of dacometinib and trials of neratinib and afatinib have been seen. Unfortunately, all these trials, look at dacometinib, response rate was only 11%, very short-term duration of response. Afatinib worked 14% response rate, again, very short-term response. So clearly, even the pan-HER2 inhibitors in the HER2 mutation space was never showing a great response, which is lasting a long term. So then the thought came, why don't we use selective HER2 inhibitors? And that's where we have seen the maximum response even in breast cancer. When we talk of selective using HER2 inhibitors, in breast, we talk maximum of tucatinib as a HER2 selective inhibitor. Here, we also we saw data from poziotinib, which is a selective HER2 inhibitor. Again, response rates were decent. There was 35% response rate, but PFS was about 5.5 months. We do get response, but the response is not lasting very long. It's about 5-6 months in most of these drugs. Pyrotinib, again, the drug coming out, response rates of 30%, PFS of 6.9 months. These are very small studies, small patient population, but all of them showing, yes, you can get some amount of response using the selective HER2 inhibitors, but again, the response rate duration is not very long. So the thought was, can we get better? And that's where we are moving forward more and more. There are new anti HER2 selective inhibitors. There are very new ones running from various companies, and these are the new ones which are going and giving us very high response rates. We have seen early phase 1, phase 2 data from the new drugs which are giving us high responses. And these are the ones which everyone's awaiting the clinical trial results for future use. So the other side was, what else can we do for our HER2 mutations? And in the last couple of years, our practice is changing very rapidly because of the availability of the new antibody drug conjugate, trastuzumab deruxtecan. Now, we know trastuzumab deruxtecan is the antibody is anti-HER2, and we know it has a linker, and we know the payload topoisomerase 1 inhibitor with a very high drug to antibody ratio of 8. This drug is changing the way we thought about practicing initially in HER2 positive breast cancers, but suddenly this drug has changed how we practice management of any HER2 cancer in the body. And similarly, this was also looked at with the HER2 mutant non-small cell lung cancer space. And this started off with what was called the Destiny Lung 01 study. Now, Destiny Lung 01 study was a phase 2 study. It was looking at non-squamous lung cancers who had progressed on standard chemotherapies, and they were patients who either had two cohorts. Cohort 1 was looking at HER2 overexpressing tumors, and they said this could be IHC2 plus or IHC3 plus. And the cohort 2 was looking at HER2 mutated tumors. Now, this was the initial study come out, and there the dosing was 6.4 mg per kg 3 weekly. That was the dose which was chosen in the initial phase 2 studies. And what we saw in in the analysis of even with the expanded cohort of 91 patients, you saw in the HER2 mutated cohort an overall response rate of 55%, a median progression-free survival of 8.2 months, and a median overall survival of 17.8 months. Now, this was clearly a response which took everyone by something which everyone noticed, because the response rate is higher than 50%. And what's more was, it was the duration of response in the PFS. You started getting a longer PFS of 8.2 months. And though this is a phase 2 study, so the median OS 17 months is in a very selected population. Now, the issue with the drug we know is ILD, And also in this trial, in the Destiny Blast Lung 01, what we saw, drug-related ILD in 26% of patients, with 2 out of patients of 91 having ILD-related deaths. Now, this clearly but is a response which is clearly telling us this drug is very active, and it was taken up in the Destiny Lung 02 study. Now, Destiny Lung 02 was the next study looking at in the HER2 mutation population. It was looking at randomizing 2 doses of TDXT. One was the dose which we took up 6.4 mg per kg in the Destiny Lung 01, where we saw a toxicity which was quite significant. So the whole thought was compare it with 5.4 mg per kg, which is the breast cancer dose which we use for TDXT, looking at 5.4 mg per kg 3 weekly, and it was a 2:1 randomization, looking at overall response rate as the primary endpoint. Now, what we saw in this, if you look at 5.4 mg per kg, the 102 patients, you had a confirmed overall response rate of 49%. You had a duration of response of 16.8 months, a median PFS of 9.9 months at a median follow-up of 11 months. Now, clearly, good responses, good duration of response, good PFS. It's clearly very significant for us in clinical practice when we look at these numbers. Even when we compare these numbers with the numbers which we saw from the oral TKI group, or the oral, or with the other monoclonal antibody with the trastuzumab era, or the trastuzumab plus pertuzumab, we are clearly seeing this is much more significant. Now, 6.4 mg per kg did give a slightly higher response rate of 56%, and the PFS was also higher. But again, if you look at the curves, actually, they are very, very similar. The issue always comes. So another thing about the waterfall plot, if you look at it, clearly telling us these were patients with, irrespective of the type of HER2 mutations, they were responding, and these waterfall plots clearly tell us the response is really very significant. Now, the issue always comes in safety. With trastuzumab deruxtecan, the major worry is always ILD, and that's been the worry for all of us when we use TDXT in clinical practice. The guidelines are very, very strict, and we know if patients get into grade 2 toxicity also with ILD, with TDXT, they cannot be actually rechallenged with TDXT again. And grade 1 is just radiological. Grade 2 is if they become symptomatic, that means you have to treat them and you don't rechallenge them with TDXT. So this is very worrisome for us. And we know if it gets into higher grade ILDs, these patients can have a very poor quality of life. And even if it becomes toxic, it can have life-threatening complications. So ILD is always a worry. And that's one thing in TDXT, we always talk about ILD. What is the percentage of ILD? And what will be the risk to our patients when we are going to offer them? Now, breast cancer patients, we are not so worried because their lungs are okay. In lung cancer patients, the lung itself is affected. And if they end up with ILD, they're going to get more breathless. And that's what keeps worrying us when we talk about treating lung cancer patients with TDXT if they develop ILD. So they looked at what was the rate of any grade ILD. When you did with 5.4 mg per kg, the ILD grade was, the any grade was 12.9% and the grade 1 was 4%. Now, if you looked at the higher dose at 6.4, the any grade is 28% and grade 1 is 8%, grade 2 is 18%. Clearly, we are getting a much higher risk of ILD with TDXT at 6.4 mg per kg compared to the 5.4 per mg per kg. Now, this data is clearly telling us it's better to be at 5.4 mg per kg. Your results are almost the same. Your responses, your duration of response is almost the same, and your ILD is much better. Now, looking at this data, in November 22, US FDA actually gave accelerated approval for TDXT for non-small cell lung cancer with activating HER2 mutations, those who had received prior lines of systemic therapy, and it clearly said the recommended dose is 5.4 mg per kg every 3 weeks. We also know these are patients who can have CNS metastasis. So we always in the present era talk what happens with CNS response for most of these drugs. Most of the newer drugs, we ask what is the brain response. And here what we saw clearly the drug does work in the brain also. We had a 50% response intracranially when we used TDXT at 5.4 mg per kg. Now, mark you, these are very small numbers. Only 14 patients had baseline brain metastasis, but 50% of these patients did show response. Now, this is, we know TDXT is a big molecule. We always say, how will it cross the blood-brain barrier? But we have seen already from the breast cancer data, it shows an excellent response in the brain. Patients with brain metastasis, HER2 positive in breast cancer, clearly go to regimes in the second line setting. TDXT is clearly one of the best regimes to go to. It is giving clear intracranial response, and also the duration of response is very long. Similarly, we are also seeing here intracranial responses there, and these patients are getting benefit in spite of having brain metastasis. So for HER2 mutations, as per treatment of choice, uh, we say TDXT is clearly a very effective drug, but 5.4 mg per kg is the standard of care. It's the same dose as the breast cancer patients. We have seen activity across various HER2 mutation subtypes. It really does not matter which type of HER2 exon mutation, insertion 20 mutation you have. The benefit was seen in all the group of patients with TDXT. It also showed very promising CNS activity with clear intracranial response rates. So we know this is a go-to regime for our patients with brain metastasis. And we've seen the FDA approval. It is approved as a second-line therapy as of now for those patients who got prior systemic therapy and progressed. This is where, for HER2 mutations, we have a clear approval for using TDXT. Now, what has become very interesting is something that we've gone round a circle. In lung, we said HER2 expression is not important. We said HER2 mutation is what we should look for. And we kept emphasizing this. If you say HER2 in lung, is it mutation? Is it ever expression? And we said, no, mutation is more important. And that's the one we used to treat. But recently, with the Destiny Lung 01 study and the data with the way the results came out, suddenly HER2 overexpression has also become very important in lung cancer. Now, why? If you see the way the trials were done in Destiny, they had a cohort which was HER2 overexpression, and they also used 3+ and 2+. And what we saw a clinically a response rate in the overall cohort was about 13% and 14%. Not very great when you look at the overall population, but when you pull out the selected 3+ positive patients, what we saw from the Destiny Lung, we have an overall response rate of 52% and a duration of response of 6.9 months. Now, this is something we had not seen earlier from our HER2 IHC 3+ data sets with using drugs like trastuzumab or using drugs like other TKIs or other anti-HER2 drugs. So clearly, HER2 expression now is suddenly become more important in lung cancer. We are now again going back and talking to our pathologists that we have to do a HER2 IHC also in lung cancer. So we've gone through a circle now. Now in our center, we are talking, when we do a biopsy, we tell them, yes, give us a sample for molecular testing. We are doing an NGS. We are doing a PDL1, but we are telling our pathologists in-house, please finish a HER2-NEU IHC at least, quickly, because that's something which is clearly changing our practice again because of this new data sets. Now, so HER2 overexpression, it's a full circle, but now again, all of us will have to do this because HER2, we've seen the recent TDXT got approved in the HER2 IHC 3+ solid tumors with the pan tumor approval on April 2024. Now, with that approval, clearly the pan tumor had multiple tumors. It had the gynec tumors, it had the GI cancers, and now we also included the lung cancers into those. So clearly, IHC 3+ is important in lung cancer, and trastuzumab deruxtecan becomes a drug of choice after chemo has progressed. So as a second-line therapy for these patients. So overexpression HER2 3+ also becoming important and having a clinical utility. Now, why are we so interested in HER2? And there have been multiple institutes in India which have published their data from tumor. When they looked at HER2, they all saw that there is a percentage of HER2 which can vary between 5%, 7%, looking at tumor NGS. This was one of studies done with looking at blood NGS, and there were multiple samples just collated from all over the country. Now, this is really not a study looking at first line, second line, third line, or any of that line. They were just lung cancer patients who had done a blood-based NGS. And this was a study where all of them had underwent a Guardant blood-based NGS and was just looking at what is the profiling of mutations. And there were 120 patients. And what surprised us, So what didn't surprise us was EGFR at 28%, and that's what we talk about in India. We talk about having 30 to 35%, anywhere ranging from 25 to 40%, depending on what study we read. So 30% is what we talk about EGFR mutations. What surprised us was our ERBB2 mutations. So these are the HER2 mutations at 11%. That's quite significantly higher than what we thought about. And these are mutations, these are not amplifications. So you're talking of selected mutations of 10% in just a subgroup which is random. Uh, we did see the usual other mutation profiles, but believe me, we have seen this in our practice now. When we are doing more and more NGS, we are picking up a lot more HER2 mutations than what we thought. It's so much higher than the ROS1s. We talk about ROS1s so much, but ROS1s, 2% of ROS1s, and we talk about those rare RETs, which is again 1 or 2%. This is much more higher. It's somewhere around 10% in this study, and there's so many studies from India showing different percentages. But these are targetable patients, and these are patients who it can change the whole survival of this group of patients. So it's really worth chasing and looking for HER2 mutations in lung cancer. Now, I would like to kind of just quickly go through two cases scenarios to see what happens in clinical practice. This is a 71-year-old male non-smoker who presented to us on February 2018, adenocarcinoma left lung, had surgery and he had a PT2N0M0 stage 1B disease. They had an NGS done for him, and it was a HER2 exon 20 mutation. Now, he did not receive an adjuvant therapy, which is probably perfectly correct because in 1B, adjuvant chemo is still not, may be given or may not be given. So that's the standard of care. Now, in September 2021, he presented to us with back pain, and a PET scan showed increasing lung mass, and it also showed multiple bone metastases, which are active. His CA was elevated. He was diagnosed to have recurrent adenocarcinoma lung with bone metastasis stage 4 disease. And we didn't have tissue, so we just did a blood NGS. And in the blood NGS, we picked up again the same ERBB2 exon 20 insertion mutation. This is almost the same one which was there in the earlier tumor biopsy. We knew this was a driver, but this was first line setting. So first line setting, our treatment was still based on chemotherapy. So he got pemetrexed carboplatin from September 2021. PET scan after 3 cycles showed good response. He completed 6 cycles and then went on to maintenance for 12 cycles of pemetrexed till May 2022. In May 22, PET showed disease progression. So he's got 8 months of chemo and he's progressed. And this is the time when the data was coming out. TDXT was showing such good results, and this was a second line setting. So he said he wanted the best of care. We said, let's start with trastuzumab deruxtecan, and that's what we did in June 22. Now, a PET scan after 3 cycles showed again a very good response. He continued on TDXT with PET scans every 6 months and MRI brains at regular intervals, and he continued to do very well for almost 2 years. Now, after 27 cycles of TDXT in March 2024, a PET scan showed again there was disease progression. Now, that is the time we said, okay, let's switch therapy, and we switched to chemo with bevacizumab. And within 2 months, he progressed again, clearly telling us chemo doesn't really work very well for these patients and these mutations, but that's what we go to because that's the only option we have for most of our patients. So this patient started approaching other options of treatment, and he got access to getting to a new anti-HER2 drug TKI, which was being available in other countries. So he kind of wanted a bridging therapy. So we said, let's get back to TDXT and see, it will give you enough time. And when we restarted TDXT, he again responded. And in 3 cycles, he has stable disease. He continues to be on TDXT while he is now trying to access the new oral TKI. So clearly, HER2 mutation, clearly very good response with TDXT, and we are extending survival. We are getting those responses and those extended PFSs which we want in these patients. Now, quickly, I will conclude with the second case. This is a 70-year-old male non-smoker presented to us in April 2021 with breathlessness. Scan showed lung mass, nodes, multiple bone metastasis, multiple lung metastasis, liver metastasis, pleural effusion, very symptomatic patient. A biopsy showed adenocarcinoma, and that's the time he had undergone single gene testing. EGFR Al-Cross was negative, PDL1 was negative. That's the time we saw him. For us, it is very standard in lung cancer. We asked for a NGS testing, and in the NGS, we found he has an ERBB2 amplification, and he also has an ERBB2 mutation. That's what we talk about. There is a lot of heterogeneity in ERBB. You can have patients you will see having both the abnormalities, having mutations and having all amplifications also. And this is what we are seeing in many patients when we are doing NGS testing for more and more patients of adenocarcinoma lung. Now, this patient, we had data from the TKIs. So we started the TKI with dacometinib from April 2021. In 2 months, when we did a scan, we did get some response. But in 4 months, by August 2021, he progressed again. He became very symptomatic. We immediately switched to chemotherapy. Now, that's the time when we thought the HER2 amplification is there. Let's add trastuzumab. We know it works for amplification, though it may not work for mutations. We did add chemo trastuzumab. He responded again, and we continued this trastuzumab maintenance for 7 months, and he progressed again in March 22. Now that's the time we changed the chemo and again continued chemo trastuzumab. Did work for about 5 months. You do see these short-term responses, and he again progressed on July 22. Now that's the time we offered him ABCP because we believed ABCP, immunobev chemo does work for a group of patients. Unfortunately, we don't know who those group of patients are, but he did not have any contraindication to this. We offered him ABCP, and this worked really well. In 3 cycles, he dramatically improved, the PET scans improved, and he continued this for just more than a year. Very good quality of life, 13 months of ABCP, and August 23, he progressed again. Now that's the time we said we have limited options. We told him that the best treatment could be TDXT because of his ERBB mutations and amplifications. If he can access it, that may be the best treatment. So August 23, we started TDXT, did a scan in 2 months, saw a very good response. The liver metastasis just shrunk down dramatically. He continued to be on TDXT with regular scans. After some time, due to finance, we actually we tapered the TDXT. We again saw slight progression happening. So then we went back to regular TDXT again, and we again saw response. Now, 1 year of TDXT, he continues to show a good response. Clearly, we are seeing that we are changing the survival of the ERBB2 mutant patients, or even the ERBB2 amplified patients, but mutant much more, using anti-HER2 therapies, and especially using TDXT is really helping these patients. And clearly, we are improving their responses, PFSs, and also the overall survival. So I would like to conclude, in every adenocarcinoma lung, also look for ERBB2 mutations in the NGS. It is very, very important. It is not a very small number. So it is worth chasing that and looking for that mutation. What's more interesting and what's more changing in our algorithm is we are now having to ask for HER2 IHC testing to look for HER2 3+ overexpression. And this is something that we have also changed in our center now, going back to our pathologists and telling them to do a quick HER2 IHC with, when they do the PDL1, we also say, just do an IHC of HER2 also, and then give us a tumor block to send for NGS testing. Of course, we are also doing more and more blood-based NGS testing. So this is also becoming important. The standard first-line therapy, even today, is a platinum doublet with or without immunotherapy for a HER2 mutant patient. A second-line approval is for trastuzumab deruxtecan for now. I say for now because clearly we have seen the Destiny Lung other trials are on, and we have a clear randomized first-line trial of TDXT versus chemo plus immunotherapy. And all of us are hopeful and think that TDXT being more having a higher response, having a longer duration, probably may turn out to be positive. And then there would be a juggling in the space. When you talk to many experts, they say they prefer, for a HER2 mutant, they actually prefer trastuzumab deruxtecan as a first-line therapy, but the FDA approval clearly says it is a second-line therapy. We think the algorithm will shuffle and there will be changes, but the best thing in HER2 mutants is we have therapies by which we can improve survival and quality of life of these patients. So thank you very much.
Thank you, sir, for this insightful talk and ending the presentation on a very positive note where we see a lot of treatment options for HER2 positive patients. Yes, since we will be taking some time in typing, I have one question. How do you see the benefit in pre-screening for HER2 mutations for lung cancer clinical trials, especially for non-small cell lung cancer and small cell lung cancer?
Pardon me, I didn't get the. How do you see the?
How do you see the benefit in pre-screening for HER2 mutations when it comes to lung cancer clinical trials, especially in non-small cell lung cancer?
Okay, so I think screening for HER2 is going to become more and more important. And in lung cancer, it's become important in every cancer, looking for HER2. And that's because of the way the TDXT data came out, the way trastuzumab deruxtecan is working for patients. Uh, that's the reason why it was taken up as a pan HER2 approval. And that's why it was looked in many different cancers. So similarly, in non-small cell lung cancer, definitely we should look for it, and it is very important. In small cell, HER2 may not have much role to play. In small cells, we have seen how the drivers are different. It's not very easy to get a activate driver mutation in small cell lung cancer. So I don't think in small cell lung cancer it will play much role, but definitely in non-small cell lung cancers, looking for HER2 is very important.
Interesting. And so the speaker, so the attendee has asked, what is the status of?
Can
Okay,
I
now.
can I
Yeah,
ask?
please go ahead.
Yeah. So yeah, great talk, sir. First of all, just wondering, they haven't shown much efficacy in some of the trials, but I just wanted to hear your perspective of both immune checkpoint blockade. You mentioned bevacizumab, atezolizumab, the ABCP combo for as a last resort, and also, like, are there CAR T trials being considered? Like, CAR T usually doesn't work so well in solid tumors, right? So I was just curious. And
Yeah.
the other
So
question, yeah,
yeah. So the first part, IO therapies. So we've learned a few things from, as we've seen IOs in lung cancer with driver mutations. So we saw in the EGFR AL cross space, they're really not really working very well. We didn't know much about the ERBB2 space. Will it work well or not in that space? But whatever data we got, that small sets are showing that the responses are not very good. But because most trials only included EGFR ALK, we are able to give it to our patients. And that's the reason why many patients have get chemo plus IO even in this space. But clearly we see they are not responding very well. So IO may not be the right treatment for IO single agent, or IO in chemo combination may not be the right space for HER2 mutant lung cancer. Now, ABCP per se is a different regime in many ways, because in spite of apart from the IO, it has the bevacizumab, and I think Bev adds a lot to adenocarcinoma lungs in many ways.
anti-VEGF agent, right?
Yeah,
Anti-angiogenesis agent.
anti-VEGF. So
Yeah,
Bev is the anti-VEGF drug. So when you add chemo, anti-VEGF, and IO, there's a different change in the milieu, and I believe ABCP works in some resistant population very well. That's my personal experience. So I think ABCP has space, but again, it is less used because many people don't like to add Bev, saying that toxicity may go up because bleeding risk goes up in lung cancer. So there is a selected space of ABCP. CAR T is a very interesting question because CAR T is being tried out extensively in various clinical trials.
right,
Unfortunately, as of now, CAR Ts are only good for leukemias and lymphomas, myelomas, that's hematological malignancies. In solid
right,
tumors, we still don't have much CAR Ts as of now for clinical use, but clinical trials are on, I would say that.
right. Thank you. And if I can ask a second question, which was, you showed us a bunch of mutations in HER2 neo mutations, right? So has there been a characterization of does, like you said, there were mostly insertions, a large fraction of them were insertions. Is there some characterization of does which mutation it is influence clinical presentation and disease progression and survival, and could there also be a link to IO and other targeted response based on what mutation it is?
No, it's a very interesting question. They have already shown in that small data sets that some mutations have a propensity for brain mets and some don't. So
Right,
clearly we are learning that those mutations may have a different clinical profile. But
right,
what the TDXT trial, what they did was they looked at each patient in the waterfall plot, what they had and what response we had, and eventually they showed that all of them respond. Really doesn't matter. So it's thankfully good for us, because as clinicians we find it very difficult to interpret these types and subtypes of mutations. So for us it becomes easier that TDXT can be used for everyone. But it's a small population, but I think surely there are data sets coming out saying that there could be differences, at least in the clinical presentations.
Thank you so much. Yeah. And
Thank you, Dr. Amit. I have one more question for you, which is what is the dosage for the ADC and selective HER2 inhibitors which lead to the improved ORR?
With trastuzumab deruxtecan, what we had was earlier the breast cancer dose is 5.4 mg per kg every 3 weeks. Now, in all the other cancers, initially when the trials were done, the dose chosen was thought maybe it should be a little higher than this, and that was 6.4 mg per kg. So the initial trials in lung used 6.4 mg per kg, but we definitely saw more ILD, and ILD can be very worrisome for these patients. So that's why uh, what Destiny Lung 02 did was compared 5.4 versus 6.4 and said you get the same response with less toxicity. So now the dose is 5.4 mg per kg as standard for trastuzumab deruxtecan in almost most cancers.
Very interesting. Can we have few more questions if people want to ask? They can raise their hands and then they can go ahead. Yes, Dr. Vitala.
So namaste and a fantastic talk. Really enjoyed as it's been always. It's always pleasures listening to you. So when you mentioned that for all the patients, slowly clinicians are moving towards the comprehensive profiling, and this particular comprehensive profiling has become a subjective talk, sir. According to you, what should be a comprehensive panel, sir?
Yeah, so that's very that's becoming very important of how much to choose in lung cancer. Now,
Yes.
so if you remember when we were doing single gene testing, then we said, okay, we started doing NGS testing for many lung cancer patients, and people were providing some coupons for 12 genes, 9 genes, 8 genes to do lung cancer. Now, when you looked at those genes, actually they did not have HER2 insertion mutations that time. They were not there in that gene panel when they used to give us 8 and 9 genes free testing and all that coupons were used. So what we clearly learned, you're missing so many patients who could be potential treatments. And sometimes in your mind, we keep thinking, oh, we have tested enough because we did the NGS. So the whole thought is, it's just not the word saying that we are doing NGS. It's important to understand what all genes are we covering. Now, to me, in lung cancer, I don't think we should be happy with just saying we have done this 9, 10, 12 genes. We should really look at more. We should get all the targetable genes, but we should also start getting more information. For example, I kind of think for all my patients, I think in that NGS, there should be an STK11 and keep one also, which people were not doing earlier. And they said that, why is this required? This is not one of the targetable genes. But for me, an STK keep 11 is important because it may point towards resistance to immunotherapy. I will look at it in a different way. So I feel it should be, so probably we should say probably at least we should cover up that 50 genes or so, which are very important. And the rest of them may be an extra information. Secondly, also important for us is fusions. And sometimes just by doing DNA NGS, we are missing fusions. So it's very important. Have we covered all the fusions and not missed out any of the fusions? So I think all this is important. Understanding, have you covered all the targetable genes? Have you covered by RNA fusions? Have you looked at all the other genes which are in fusions? Have you looked at genes which are now pointing towards resistance for future? So these are all to be included. Now, every oncologist who treats kind of adapts slowly and changes as they see their own experience gets evolved. And I myself can say in the last 3-4 years, we are learning so much every day. It was we never learned all this in one time. We used to say, okay, we are happy with small NGSs. Now we are saying, let it be more comprehensive. But again, as we say in India, cost also matters for all our patients. So that's again, we have to be vigilant about what we are spending and what we are getting. So cost also is important. But we should at least have all the information in lung cancer as much as possible on day one.
So thank you so much for this, Dr. Amit sir. And when you mentioned the cost, which becomes a predominant factor in the Indian clinic while you are practicing, and you also mentioned about the importance of RNA fusions. A curious question, sir. In your current practice, do you get is there a ready-made assay with you which addresses all your requirement? The cost, the fusions, the minimum close to 40-50 actionable mutations. Is there a ready-made test for you, sir? Ready?
No, I think definitely it's there. It's there now. Now all the labs, like even your lab and other labs, all of them are are understanding the clinician's requirement. And the best thing is all of us are talking to each other and we are understanding each other's requirements. And that's the reason why we are covering better gene panels, better coverage, trying to get everything included. And I'm happy with what we are getting from most of our labs, where we are getting it done in such a way that we are not missing out much on day one.
Thank you so much. Thank you.
I think there's some questions in the. So there was one question asking about the dose of Indian patients. That's
Yeah.
Yeah.
A very interesting one. Should I read out?
Yes.
So the dose determined for Indian patients is different to Western patients. Would you see a need to extend the Destiny study or a new study for more Indian patients wherein we include both HER2 screening and IHC?
Yeah. No, I think this always is a very important question for Indian settings. We kind of believe our there is always differences, and there could be differences in our whole pharmacogenomics and the way things are. But the issue is it's very difficult to do studies in each population. It's never going to get done. So I think what will happen is we will adapt, and if we see toxicity much more in our initial experience, we will definitely try to cut down and see whether it's a different dose which is required. But I can tell you of using trastuzumab deruxtecan, 5.4 mg per kg is a dose working well for our patients, and we now a good number of patients in various malignancies showing good results. So I think that seems fair enough for our patients.
Thank you, Dr. Amit. Next one is, does lung cancer have a hereditary component? If so, could you please explain which genetic tests are recommended to assess hereditary risk for lung cancer?
So again, another interesting question. Lung cancer has very, very little of genetic hereditary component. So lung cancer is one of those cancers where really we believe it may not be a hereditary cancer. But all said and done, we now have a few patients of lung cancer who have BRCA mutation, which is germline. And now we have pulled up these patients. There are a few patients we have. But again, BRCA is not a usual driver for lung cancer. So we clearly say lung cancer is not one of those hereditary cancers, and we tell all our patients we really don't need to go germline testing for most of these patients.
Okay. This is the second last. Are all these patients tested for germline mutations also with tumor tissue?
So no, we don't do germline testing. What if you see the blood test which you see is the blood NGS? We are asking for blood cell-free tumor DNA testing. That's what we are asking in lung cancer. That's why we're saying in lung cancer, it's very important, do a tumor NGS, but also do a blood NGS, because with tumor, you miss some, and with blood, you miss some. So when you do both, you probably are picking up maximum and not missing out on the driver mutation. So that blood which you see, the blood sequencing, those are blood tumor, cell-free tumor DNA sequencing is what is there. In lung cancer, we are strong believers of doing both tumor and blood NGS in our center, because we don't want to miss out on many mutations. We want to catch them at the start so that our treatment goes in a most precise way.
And thank you. And this next question is about the dosage. Are these specified in the NCCN guidelines?
Yes, absolutely. FDA approves, like in lung cancer, it's 5.4 mg per kg, and that will be there in the NCCN guideline as 5.4 mg per kg. These are absolutely, the dose is approved by FDA, and even the guidelines will give the exact dose which we have to use according to the malignancy.
Great. We will now wrap up this session, but let's take up the last one. If you find BRCA germline, do you counsel the family to check family members, especially female family members or children?
Yes, if we have a BRCA mutation, we absolutely, if we get a germline BRCA, we need to do a family counseling and then a family testing. And not only female members, you also talk about the male member testing. So clearly, if you get a germline BRCA, there's a lot of discussion which goes on with the family. There's a lot of counseling. And that's the reason when we say, when we test germline testing, just don't test it blindly. You have to talk to them, you have to counsel them. You have to understand what the implications would be if it comes positive, and then you go and do the testing. So for germline BRCA testing, a lot of counseling and then sequential testing of family members is a must.
Thank you, Dr. Amit. And with that, we will conclude today's session. Thank you again for sharing your invaluable knowledge and insights with us. And I would also like to extend my sincere gratitude to all the attendees for their active participation. We will soon be notifying you about our next webinar, and we hope to see you there. Thank you once again.
Thank you very much. Thank you.